Today we're privileged to have with us Dr. Bhavya Trivedi, who is Chief of Pediatric Electrophysiology here at Florida Hospital for Children. He's well respected and well known in his field. He was graduated from the University of Miami College and medical school, and he trained at the coveted residency at Duke University School of Medicine. We're privileged, like I said, to have him here with us. He comes from a distinguished background, and he is going now to talk to us about electrophysiology in the workplace, shall we say, the ICU. What do we do about these situations? How should we manage them? And it's my privilege, of course, to welcome Dr. Trivedi to the podium.
Thanks, Gus. All right, can you hear me? Yeah. So, morning. This is a talk that I was asked to do for Heart Rhythm Society this year, and they tend to give us some interesting topics sometimes, and this one really challenged me, and I really had to do some digging and research, and to put this together, I changed the title just slightly, because the title they originally gave me was "How to Know When Not to Do an Electrophysiology Study for Risk Stratification," and they had an entire session on how to do when not to put in an ICD, when not to do EP studies, et cetera. So it was a creative way of bringing up a topic, because there is always a little bit of confusion in clinical scenarios of who needs an invasive EP study when you're doing clinical decision making. And so that's where this talk came from. And I expanded it a little bit for this grand rounds. When we think about pediatric congenital electrophysiology, there's always a thought process in our mind when we evaluate a patient. And it starts with the most basic things. Am I dealing with something that's a slow heart rate, or is it too fast? Is it bradyarrhythmia? Is it tachyarrhythmia? Is it in the setting of congenital heart disease, or is the heart structurally normal? Could it be a cardiomyopathy? Could it be a channelopathy? And very importantly, as this thought process is going on, we always have in the back of our mind, is this patient at risk of sudden death? That's the question we want to answer almost every time we meet a patient, and that's going to change much of what you do in clinical testing and management. When we think about risk assessment, there are mathematical formulas that help us understand risk. Some of these come from the financial world, from the economic world, and we try to apply them to clinical scenarios also. So if you look at this mathematically, R being risk and L being the potential loss, probability of loss is probability of L for an individual, I meaning individual. So individual risk is risk equals the individual loss times his probability that loss will occur. When you take a whole population, you sum all of this, you get the total risk. These are principles that are applied when we look at electrophysiology testing, for example. So a few words about invasive EP testing. What is invasive electrophysiology testing in contrast to non-invasive electrophysiology testing or other methods? So invasive EP testing means it's a catheter diagnostic electrophysiology study. We are trying to evaluate for ventricular arrhythmias, sometimes for atrial arrhythmias or SVT, though those are not necessarily things that are going to cause sudden death. In this study, we do what's called ventricular stimulation, either one or two sites in the right ventricle plus minus left ventricle, depending on clinical scenario, and some of this is operator dependent. Most of it is standardized and validated, but not all. And in the process, when we're doing these stimulation studies, we introduce extra beats, introduce PVCs into the heart and see how it responds. So PVC singles, doubles, triples, 3 PVCs in a row. So that there's an example at the bottom here of ventricular burst pacing. So here's a burst that induces a bad rhythm in this patient. So all of that is done first without isoproterenol and then with isoproterenol infusion. induction of ventricular tachycardia or ventricular fibrillation is considered a positive electrophysiology study. Now, when we look at these risk assessment tools, we want to know what is P, what is the probability that loss will occur. Our non-invasive methods for figuring this out include symptoms, patient's history, doing an echocardiogram, doing a cardiac MRI, doing an ECG, a Holter, see what kind of rhythms show up, event monitor, implantable loop recorder, and exercise test, stress test. Invasive studies include esophageal electrophysiology study or a transcatheter electrophysiology study. The question is, when we're dealing with an actual patient, what is acceptable risk? Especially when you consider that the loss could be sudden death, that the individual, in our case, might be a child, an adult. Does it really matter? We really want to know P. We want to know this probability, and therefore, a lot of enthusiasm has been placed on invasive electrophysiology testing. The problem with the esophageal electrophysiology testing is that it has limited utility. It's not going to help us determine whether there is risk of ventricular arrhythmia. You can't pace the ventricle. You can only pace the atrium through esophageal electrophysiology testing. Therefore, invasive electrophysiology study in the hands of electrophysiologists has become a pretty big hammer that we use to try to figure this out. So when you have a hammer, Mark Twain said, someone with a hammer, everything looks like a nail. The question is, what is the nail in our situation? Which patient should get an electrophysiology study? When we think about clinical scenarios, patients have various disorders that they come to us with. We want to put them into a nice structured model. And the structured model that we try to use for most of these situations is we try to categorize, does the patient fall into a high-risk category, moderate risk category, or low-risk category? Obviously, if they're high-risk category, they had an episode of cardiac arrest, documented VF, intervention is indicated, ICD, catheter ablation. If you're in a low-risk category, then you can reassure the patient, you can go with longer-term medication or observation. It's this moderate risk category that's our nail. We want to know which patient is in this moderate risk category and then use our additional invasive testing measures to figure out, are they high risk or low risk? So if we do have somebody in the moderate risk category, then we can do electrophysiology risk stratification. The next question is, if I do electrophysiology risk stratification, is that actually useful? Is it actually going to help me determine whether the patient is low risk or high risk? This is best demonstrated where electrophysiology study is extremely useful in adult repair tetralogy of Fallot. So Paul Carey, in his work over many years, has looked at patients with tetralogy of Fallot repaired in their adulthood. They have a higher risk of sudden death than the general population, approximately 1 to 2% per decade sudden death rate. And he took many of these patients who already had ICDs placed, whether for good reasons or not great reasons, they already had ICDs placed. And here we're not looking at sudden death, but we're looking at the rate of ICD appropriate shocks over time. And based on that, he was able to come up with several criteria that help you determine that the patient is at low risk, moderate risk, or high risk. So a scoring system was determined that includes having a prior palliative shunt. Is there inducible sustained VTAC? This is from the electrophysiology study. Is the QRS duration long, 180 milliseconds? Previous ventriculotomy incision, which our surgeons try to avoid in many of the young neonatal TETs we do now. Non-sustained ventricular tachycardia, documented on an event monitor or other monitoring system. And from cath data, left ventricular endostic pressure greater than 12 millimeters mercury. Actually, this one turned out to be one of the highest risk factors for sudden death in these patients. And if you take those scores and you add them up, then you come up with low-risk category, intermediate, and high-risk category. And you can see that if you plot these based on these point scores and take these patients, this is the freedom from appropriate ICD shock. But these patients had no ICD shocks, low-risk category, over several years. You're looking at 8-9 years here. Moderate risk, these people are having appropriate shocks. So this is a surrogate for sudden death. So the presumption here, the assumption is that these appropriate ICD shocks happened in clinical situations in arrhythmias that could have caused sudden death. And then the high-risk category, you can see how steep this Kaplan-Meier curve is. So when you have a nice risk model like that, then electrophysiology study is useful. And we know that the positive predictive value may not be great for electrophysiology studies in these situations, which it is similar in other situations, but the negative predictive value is actually excellent, better than 90%. And the likelihood ratios are 3.7 and 0.28 for a negative EP study. So if you can take a patient like that to the electrophysiology lab and prove that despite aggressive electrophysiology testing, you can induce any bad arrhythmias, that's a very reassuring finding. So non-invasive historical risk factors with some validation in adult tetralogy of Fallot includes age, QRS duration, prior shunt, some of the things I mentioned earlier that are on that grading scale, and then hemodynamic factors, LV-EDP greater than 12 millimeters mercury. As far as electrophysiology risk stratification, program STIM, is it useful in this situation? Yes, very much useful. And if you look at putting these patients into high risk, moderate risk, and low risk categories, then if you have multiple non-invasive risk factors, you're automatically high risk category. If you have documented VTVF, those patients get an ICD. If you have low risk score based on non-invasive risk factors, you don't need to do an EP study. Medical management, reassessment over time. But if you're in the moderate risk category, then those are the patients that get electrophysiology study, and we see that it's very helpful for adult tetralogy patients. So this is patients with unexplained syncope, intermediate risk score 3 to 5, based on the non-invasive factors. So when not to do an electrophysiology study, repair tetralogy of Fallot, as we said, nice risk model, high risk you don't need it, low risk you don't need it, moderate risk is where we do it. So like that, we want to use this type of model in multiple other situations. So here are all different types of conditions with high risk of ventricular arrhythmia. We know that for ion channelopathies, particularly long QT syndrome and CPVT, the electrophysiology study has very little value. In this talk, I'm going to focus now on these first four: hypertrophic cardiomyopathy, dilated cardiomyopathy, Brugada syndrome, and interestingly, and you'll see a slightly controversial but very interesting is WPW. And we already talked about briefly about congenital heart disease and repair tetralogy of Fallot. So hypertrophic cardiomyopathy, disease we're all familiar with, it's quite common, can cause sudden death. Used to be said 1 in 500 in the population, but more recent studies, especially incorporating genetic results, suggest that it's even more common. It's probably 1 in 250 or 1 in 300 families. Non-invasive risk factors are pretty well validated as a risk of sudden death in hypertrophic cardiomyopathy. This includes syncope, family history of sudden death, non-sustained ventricular tachycardia on a Holter, abnormal blood pressure response, hypotension on an exercise stress test, and severe LVH. So electrophysiology study with programmed ventricular stimulation, previous studies have shown that this has a low positive predictive value and a low negative predictive value. So electrophysiology study in hypertrophic cardiomyopathy, for the most part, is it useful? The answer is no. Interestingly, however, a recent excellent study came out, this is 2018 April, hypertrophic cardiomyopathy in children from age 1 to 16. So this took a large cohort of patients, and they did a sub-analysis of the 100 children that were in this study. This is from an Italian group. And in those 100 children followed over several years, looking at lethal arrhythmic events, 24 arrhythmia arrest events occurred in those patients. Very interesting that the risk of late adverse events associated with symptoms at onset, meaning at the time of diagnosis, and with genetics, troponin I and T high-risk mutations. The previous risk factors that we talked about, the family history of sudden death, the syncope, all those other things, those risk predictors perform very poorly in these children. So based on this study, the question of is this useful for children with hypertrophic cardiomyopathy is still out there. We don't know the answer to that. Maybe it is, and that needs to be reassessed. So when not to do an electrophysiology study when a patient has hypertrophic cardiomyopathy. If it's an adult, we use the validated non-invasive risk criteria. The exception would be a documented arrhythmia that has indications for ablation. Then you take them to the EP lab. If you have a child or teenager with hypertrophic cardiomyopathy, the risk criteria are based on adult studies. We also have to consider newer data and incorporating new information. Cardiac MRI evaluation for late gadolinium enhancement, looking at scar areas. Is there an apical aneurysm, a outflow gradient of more than 30 millimeters mercury? And then from our genetic results, is it a high-risk mutation? And the prognostic utility of EP study for patients has to be reconsidered. So moving on to dilated cardiomyopathy, this is, to be specific, non-ischemic dilated cardiomyopathy. So non-invasive risk factors for dilated cardiomyopathy, risk of sudden death, include T-wave alternans, QRS fragmentation, late potentials on the ECG QRS, or complex ventricular ectopy, and then similar to dilated cardiomyopathy, do you have a lot of scar in your heart? Cardiac MRI, late gadolinium enhancement. A very good recent study called the Danish is a randomized controlled trial, so as good as you can get, showed us that regardless of the left ventricular ejection fraction, which is a classic consideration in these patients, program stim reaches a negative predictive value of 94 to 97% and positive predictive value of 60 to 80%. So therefore, it's very good in dilated cardiomyopathy at figuring out who is at high risk of ventricular arrhythmia and who isn't. So EP study is recommended as a tiered approach. It's not the first thing you do. We do the non-invasive risk stratification first and then move forward to electrophysiology study. And this is now being considered in a lot of patients regardless of whether the LVEF is less than 35% or greater than 35%, which is one of the more classic criteria. So arrhythmia inducibility and electrophysiology validity. When we do these studies, we do have to keep in mind it is changing. So the patient is not the same when you do the electrophysiology study today as they were 6 months ago, or they may not be the same a year from now. The substrate itself is changing. Also, during the study itself, the EP practitioner has to keep in mind constantly that the autonomic tone affects how inducible a ventricular arrhythmia might be. So testing with asparterenol has to be done in these situations. So is it useful for dilated cardiomyopathy? The answer is yes. It does help you determine who gets an ICD and who doesn't. So when do you not need to do an electrophysiology study, dilated cardiomyopathy? Based on the Danish study and then other studies looking at the non-invasive risk factors that we listed, if the LVEF is less than 35% and you have more than 3, so NIRF is non-invasive risk factors, you have more than 3 of the non-invasive risk factors, you don't need an EP study. That patient gets an ICD. Moderate risk, and class 2 to 3 heart failure. LVEF less than 30% and class 1 heart failure automatically gets an ICD. Low risk category, if your EF is less than 35%, but you have no non-invasive risk factors, you may be able to continue with medical management and interval reassessment. And you have no fibrosis on cardiac MRI. Moderate risk is everything in between. So left ventricular EF, less than 35% with less than 3 risk factors, you have greater than 35% with any non-invasive risk factor or fibrosis. So we don't need to do an EP study if you're high risk and likely low risk, although based on the data I just mentioned from the Danish study, some people are arguing that even if your LVF is less than 35%, maybe those patients should get an electrophysiology study for risk stratification. So we covered adults with tetralogy of Fallot. We talked a little bit about when EP studies may be indicated in hypertrophic cardiomyopathy and in dilated cardiomyopathy. The next one that I'd like to focus on is Brugada syndrome. So Brugada syndrome, unlike long QT syndrome, which most physicians and folks in the medical field are familiar with, and sometimes CPVT, Brugada syndrome is less well understood. It is a sudden death syndrome, and it's typically a genetic mutation in the fast sodium channels, though some calcium mutations have been described. The problem with not just Brugada, but also long QT, is the first presenting sign can be ventricular fibrillation arrest or sudden death. And that's unfortunate, which means that when a patient has an ECG, if we don't pick up the subtle signs, and they can be quite subtle sometimes, if we don't pick up subtle signs of Brugada syndrome, then we're leaving those patients at risk. And also, many of these events can occur while sleeping. Family history is extremely important when figuring out patients like this. Almost all the time, somebody with Brugada syndrome will have some type of family history, even if it's a distant cousin or an uncle, or usually I focus on the immediate relatives, but in Brugada syndrome, you have to expand your genetic tree and start looking at more removed relatives also. So different types of ECG patterns that suggest Brugada syndrome. You might look at this and say, it looks like right bundle branch block. Yeah, it does. So here at V1, V2, you have this sloping ST elevation that comes down to the T wave. This is a type 1 ECG. This is the more classic one. When they have questions on the board exam about Brugada syndrome, they always show this. They never show these two. So here, this looks more like, could be an MI, ST elevation. Here it's more scooped out in lead V2. Sometimes what we ask our ECG technicians to do if we're concerned about Brugada syndrome is move the leads up. So normal position, fourth intercostal space, we move it up to third or second intercostal space. If you do your V1 and V2 from up here, you're more likely to bring out this pattern. So it's a nice, easy way, non-invasive, to bring out the Brugada pattern in someone where you might be suspicious. And then a type 3 ECG is more like a saddleback. It's a scooped out ST elevation. And you can see this V1 is quite subtle. Sometimes it shows up better in V2. The interesting thing about Brugada syndrome, there's been controversy whether electrophysiology study program stimulation is useful or not. And the answer is maybe. So it's one, you don't have to have an electrophysiology study to diagnose Brugada syndrome. In children, it can be a little trickier because these classic Brugada patterns that I showed you here don't show up. Their ECG doesn't typically show these patterns until they're teenagers, 13, 14, or older. That's where we do recommend, and it takes a lot of coordination with parents, and they have to comply for these things, is when the kid gets a fever, these patterns come out. And so when they get a fever, we tell them, don't give your child Tylenol, against what the pediatrician's saying, kids say give them Tylenol. We tell them, don't give him Tylenol, bring him in and let's get an ECG when he has a fever. I want to know if I see this pattern. There's conflicting studies on risk stratification with Brugada syndrome, and therefore, recently, a very good comprehensive pooled meta-analysis was done. Very hard to do this with the small numbers in children. This includes many, many adults. So 8 prospective observational studies totaling a lot of patients, 1,300 patients, and of those patients, 65 had cardiac events. Electrophysiology induction of ventricular tachycardia was associated with cardiac events with a hazard ratio of 2.6, which tells you that it's probably useful. The lowest risk in patients was without syncope and without drug-induced Brugada pattern. So bringing out the Brugada pattern with drugs is also a diagnostic tool. You can use procainamide, you can use flecainide. And highest risk in patients was those who had syncope and who had a spontaneous type 1 Brugada pattern. The higher risk if ventricular tachycardia was induced with PVC singles or doubles. So if you remember in the EP study, we do pacing, which is very standardized, 8-beat drive, and then you introduce an extra beat, 1 PVC or 2 PVCs or 3. If you're extremely aggressive with 3 PVCs, you might be reducing your negative predictive value because you may induce things that aren't clinically real. But here, they saw that with singles or doubles, if you got VT induced, those patients clearly were higher risk. So particularly when we think about children, is the EP risk stratification useful? Maybe, and that needs to be looked at a little further. When not to do electrophysiology study in Brugada syndrome, we need more research done. If you have syncope that's not vasovagal, documented VT-VF, or you have cardiac arrest, the answer is obvious. Those are high-risk patients. They get an ICD. If you're low risk, no syncope, no symptoms, no arrhythmia, no spontaneous ECG pattern, those patients get observation and medication. If you're moderate risk, I'm not sure there is such a category. So spontaneous Brugada pattern with ECG or brought out by fever could be considered moderate risk, and those patients get EP risk stratification. But often, we end up doing a electrophysiology study in these patients that are borderline even for the diagnosis. Moving on to WPW. So WPW, as a reminder, those of you who don't see this every day, is an electrical accessory pathway for electrical conduction from atrium to ventricle. So here's a ECG of a patient of ours that we did recently. You can see P wave, and here's your delta wave into the QRS. So when the delta wave is smaller and more subtle like this, it's more likely to be a left-sided accessory pathway, and that's what this patient had. So here's an example, an impressive one, of a right-sided accessory pathway. One of the reasons I wanted to show this is this, you could look at this and say, that looks like left bundle branch block pattern, and yeah, it does. It's because all the activation is coming from the right side from a right anterior pathway. The other point I wanted to make from this ECG, delta waves don't have to be positive. Every textbook shows positive delta waves, but in some leads, delta waves will be negative, so we don't want to miss those. So here you go, AVR. Here's another example, slightly more pre-excited, another example of a left-sided accessory pathway, which shows a classic axis that tells you it's very likely a left-sided pathway, going away from AVL and positive in V6 and V5. So what's going on in WPW? So here is diagrammatically normal sinus rhythm. Sinus node activation goes through the atria, through the AV node, and then your ventricles are electrically activated. In WPW, you have conduction down AV node and down the accessory pathway, dual activation of the ventricle, which gives you your delta wave. Under the right conditions, if a PAC happens, then it might block this pathway and then start arrhythmia, which is SVT. When you have SVT, this is WPW on an ECG, and yes, so this is a patient in SVT with WPW. During SVT, the QRSs are narrow. It continues, and on this rhythm strip, you see the patient has some spontaneous PVCs, and then it stops. No delta wave during SVT because conduction is actually going down the AV node and up the pathway. The ventricular activation is actually normal. The problem in WPW is not necessarily that these patients have SVT. SVT makes them symptomatic. The problem is you might have asymptomatic patients that have this. And this I pulled from a paper because getting documentation of this is not so easy. Here you have a patient with WPW who starts to go into a narrow complex tachycardia. Initially starts wide, probably because of a bundle branch block aberrancy, and then it becomes a narrow SVT like you typically see, but then the patient goes, this SVT degenerates into atrial fibrillation. When you have WPW with atrial fibrillation, you get rapid conduction of signals to the ventricles, and that can degenerate into VTAC and then to VF. So this is an actual recording from a patient who was sitting in the hospital, and this happened, and they caught it on the monitor. So sudden death in WPW is a 3 to 4% lifetime risk. If it's asymptomatic WPW, it's thought to be a lower risk, meaning less than 1%, but really we don't know. A lot of these patients are missed. They're missed because sudden death happens at a young age. They never really got evaluated by a cardiologist prior to the sudden death event. They get evaluated by the medical examiner who finds nothing wrong. You can't see these pathways on autopsy. And so the actual sudden death risk with WPW is we don't know. We don't do ECGs on everybody. I'm not saying we should do ECGs on everybody. That's a different debate, but that's one of the reasons we don't know the answer to that question. How we manage WPW has become an evolving thought process in the electrophysiology world, particularly in the pediatric electrophysiology world. One of the interesting things about assessing WPW with risk stratification is you're bringing a patient to the EP lab and you're doing a procedure that at the same time you're assessing the patient, but you can do an ablative cure. So unlike the other conditions we talked about, this is something we can actually fix. So we know that if you have symptoms, you have syncope, you have documented arrhythmia, you have episodes of SVT, then electrophysiology study and ablation is usually indicated. That's a class 1 or 2A indication. In addition, during the EP study, we look at what's called SPERI, the shortest pre-excited RR interval during atrial fibrillation. We actually put the patient into atrial fibrillation and watch and see how fast do the pre-excited QRSs come. And if that's less than 250, that's a validated number that tells you that patient's at higher risk. Based on those studies and non-invasive assessments, a 2012 PACES is the Pediatric Adult Congenital EP Society and Heart Rhythm Society came out with a consensus statement on what to do with asymptomatic WPW. The emphasis from that consensus group was put on whether you have persistent or intermittent WPW and what happens during an exercise stress test, all as part of the non-invasive risk assessment. This was very similar to the adult consensus WPW statement that came out in 2015. So keep in mind here, we're not talking about patients who come to you complaining of palpitations. These are patients who are asymptomatic, came to the ER perhaps with chest pain or something else, non-cardiac, got an ECG, and there it shows WPW. Came to the clinic for a physical sports assessment. More and more pediatricians are starting to get ECGs on those patients, and there you go, you find WPW. So now you know, all right, this patient has a small but real risk of sudden death. What do you do? So is it intermittent WPW? Is it persistent all the time? What happens when we run them on a treadmill? The interesting thing is there are too many concerning intangibles in these situations. So over the last 15 years, there have been several reports, and I say several, more than 10 probably, patients with intermittent WPW having cardiac arrest. This made us pause and think. The other thing to consider is that when we look at ECGs, like the first one I showed you, that delta wave can be somewhat subtle. There's poor inter-observer reliability of loss of delta wave during the stress test or even on baseline ECG. When you run on a treadmill, AV node gets better, the delta wave is gonna get smaller. Knowing and seeing that the delta wave is actually still there or not can be tricky. The other problem is, are these patients truly asymptomatic? And I'm gonna give an example of that. So when we do electrophysiology risk stratification, we can do ablation at the same time. Is it useful? Yes, of course it's useful. There are good invasive and non-invasive risk assessment tools for WPW. Teenagers aren't normal. So here's a teenager that we took care of just a few months ago. And this is a patient who actually came in symptomatic, complaining of palpitations. Is this PR's measures pretty normal? There, yes, I blew this up. PR is maybe slightly short, but if you measure it out, 120 milliseconds, not so bad for a teenager. You look at V6, there's a slight Q wave in V6. You might look at this ECG, call it normal. I did. I pretty much called it normal. Took the patient to the EP lab because of her symptoms. Take her to the EP lab. Here's the baseline ECG in our electrophysiology study. Looks very normal. Start pacing the atrium, nothing else. We're just pacing the atrium. Huge delta wave. This faster pacing. This patient had WPW, ECG looked normal. That scares me. That's a scary finding. The good thing is she did have symptoms. She had palpitations. We had high suspicion for SVT, and therefore we did the procedure and were able to cure this. Interestingly, this patient had a left lateral accessory pathway with a ERP, so the refractory period. When the refractory period is less than 250, we know that those are at risk of sudden death. This patient had an AP ERP, accessory pathway ERP of 220 milliseconds, and a shortest pre-excited RR interval during AFib of 210 milliseconds. Extremely fast pathway. This patient was not a 1% risk of sudden death. This patient was a high risk of sudden death. Here's another case. Asymptomatic 16-year-old male, found to have WPW on a 12-lead ECG, incidental finding. His pediatrician sent him in, very athletic kid, wants to do a lot of sports. He said, all right, I think physically you're fine, let's get an ECG, make sure you're good I don't have to worry about you when you're doing sports. ECG shows WPW. All right, so we took him to we followed the consensus statement. What's the next step? Athletic kid, no symptoms, never passed out, no palpitations, etc. Take him to the stress lab, and at a heart rate of 120, very clear, delta wave goes away. No problem. We're feeling good about this patient. He tells you, I never have palpitations. It wasn't me, one of my partners, it might have been Dr. Ramos, gave him an event monitor anyway. Thank God they did. Wearing an event monitor, he's at the gym, after drinking some coffee and an energy supplement, not so recommended, but anyway, that's what he did, goes to the gym, and we record this on his event monitor, 290 beats a minute, narrow complex tachycardia. 16-year-old young healthy kid. This goes on for several minutes while he's weightlifting. Never felt a thing. Never felt a thing. I don't trust the teenagers at all. They tell me they're asymptomatic, and we get things like this. Young healthy heart, his cardiac output was probably 30% of normal, where he normally is. During this event, he didn't even feel it. He got through his workout and went home, felt great. So this is orthodromic reciprocating tachycardia from WPW. He had a left lateral accessory pathway, and this was successfully ablated. Was he at high risk for sudden death? Probably not. But he had clear SVT. So the question of whether a patient is symptomatic or asymptomatic, we have to be really careful in those histories. And maybe we should be doing more of these types of event monitors in those patients, even when they say that they're asymptomatic. So going to this consensus statement algorithm from 2012, children with asymptomatic WPW, baseline ECG, and then it focuses on whether the pre-excitation is intermittent or persistent. You do a stress test. Does the stress test give you the go-ahead to do an electrophysiology study? When you do an electrophysiology study, we look at EP measurements. We measure how fast is the AV node, how fast is the accessory pathway, and we come up with criteria. And then based on those criteria, is it a class 2A indication, class 2B, consideration of ablation, discuss the risk benefits of ablation, if you have inducible SVT or a Sperry less than 250. Unfortunately, this doesn't always work. It took about 20 years of work for this paper, and you can see multi-center how many authors there are because there were so many centers involved for gathering the data in children with WPW and looking at life-threatening event risk in those patients with WPW when it's asymptomatic. So these are new insights. So patients who were obviously male or female sex did not change the odds ratio. So predictors of life-threatening events, multivariate analysis. All right, so males did have a slightly higher, but the p-value was pretty good. But the electrophysiology findings, having a very short ERP, effective refractory period of the accessory pathway, having a short pre-excited intervals during AFib, having short accessory pathway block during atrial decremental pacing. All of these were the best predictors of whether the patient was at high risk of sudden death or not. Presence of Epstein's was also high risk. Inducible AFib at electrophysiology study puts you at high risk. And if you have more than one accessory pathway, that also puts you at high risk. Unfortunately, they took all these criteria and then looked at the patients who actually had cardiac arrest or a sudden death event. So here is the fastest RR interval during AFib, accessory pathway ERP during atrial decremental pacing. The patients below the line, you would automatically say they're at high risk. Unfortunately, you had all these patients of actual cases. These are controls. These are actual cases. Actual cases, you had all these patients who would not have classically met the EP criteria for ablating that pathway. And those patients had cardiac arrest or sudden death. That makes us rethink our process. And a straight quote from this paper, so out of 60 subjects where 2 of these high-risk categories, risk characteristics were measured, EP risk, so we're talking about these findings. More than one accessory pathway, all of the ERP testing, and having AFib. If you had that, 37%, so if you were to rule them out as high risk based on that, you would have missed 37% of the patients who actually had cardiac arrest or sudden death. So that brings us to doing WPW ablation. So if you were to take a patient who is asymptomatic, doesn't have documented SVT, never had syncope, you take them to the lab, they not necessarily have high risk criteria based on the EP findings, we know, all right, there's still a small chance this patient could have sudden death. Should I do ablation or not? Brings in the question of what's our ablation success rate, what's our safety? And it turns out that with WPW and AV reciprocating tachycardia, ablation has better than 95% success across all centers. And our success rate here is this or better. Complication rate is extremely low, way less than 1% of any major or minor risk, really. And at our center now, fluoroscopy time and radiation is now 0, and for almost all procedures. Here is an example of even sometimes complicated scenarios. This is from our 3D mapping system, no fluoroscopy used. This is in a young patient, like 8 years old. This is actually the coronary sinus. So 3D geometry looking at an LAO view of the coronary sinus. Here's your His catheter, right atrial catheter. This is looking at it from an REO view. You're looking into the CS right here. That's the CS catheter, the blue one. This patient had a CS diverticulum, and we were able to create the geometry not only of the coronary sinus, but also of the anatomic malformation. When you have CS diverticula, many of those patients have WPW pathways that live within the diverticulum. This blue dot is a cryo lesion that ablated the WPW pathway in this patient. All of this done without fluoro, with a high level of safety and good success rates. So one of the ways that we eliminate fluoroscopy is by using ICE, intracardiac echo, and with experience, and we're not the only center doing this now, we can use ICE to put the probe here in the right atrium, look at the septum, and do transeptal puncture without using X-ray. So here's the video. You can see the needle that's just poking there, starting to indent more, and then the needle goes across. On the next slide, you'll see that the sheath has been placed across to the left side. This is just looking a little higher to ensure that you're not too far into the left atrium, and saline is injected, and you can see the contrast here from saline going into the left atrium that confirms your left atrial access. So this can be done even in patients as small as 25 kilograms. So when we take all this into account, the safety, removing the fluoroscopy usage, the high success rate, then it's not just me, but all my colleagues in the Pediatric EP Society are really starting to reconsider this 2012 consensus statement on children with asymptomatic WPW. So the new consensus algorithm that even if you have intermittent pre-excitation, when you get to this point, that maybe all of these patients should have an electrophysiology study and maybe they should all be ablated. We don't want to miss those 37% with high risk EP criteria, with low risk EP criteria who ended up having a bad event. So in WPW, when do we really not need to do an electrophysiology study is really only the low risk category. No syncope, no symptoms, no documented arrhythmia, complete loss of pre-excitation with an exercise stress test. Those patients, most people would agree, you can observe and follow up. There really is no moderate risk category. And high risk is obviously those with syncope, with symptoms, WPW persistent with stress test. And based on some of the data I just showed you, some people are taking these patients also to the lab, especially the kids. So in summary, electrophysiology study, useful tool for risk stratification, but it's not indicated. Low risk situations, when you can determine that by non-invasive methods, it has low positive predictive value and negative predictive value for certain conditions such as hypertrophic cardiomyopathy, long QT syndrome, CPVT, risk of the procedure, or if the risk of the procedure outweighs the benefit. EPS for risk stratification in children needs further research, particularly for hypertrophic cardiomyopathy and Brugada syndrome. Here's the risk model that we discussed earlier, where all these studies are done looking at many patients, looking at populations. When we're looking at the one patient in front of us, the process has to be individualized management, and based on not only the physician and clinical team's risk tolerance, but also the patient and family's risk tolerance has to be kept in mind. Thank you.
Thank you, Bhavya. Is this on? Thank you, Bhavya, for a wonderful, comprehensive review of a very difficult subject. I was thinking about, and we might have time for another question as well. I was thinking from the Olympian view of this situation. Other things can cause tachycardia or patient death and resuscitation, such as coronary lesions and the like.
Yeah.
Tell me, And this is a specific question that is having to do with our population here or anywhere. Is there room in the high school population for, and should there be, canvassing, shall we say, with electrophysiology or for an electrocardiogram or an echocardiogram? Is that something that will be helpful to patients who have this and haven't been identified?
Yeah, it is helpful. The problem has...
That costs a lot of money.
It costs a lot of money. It costs a lot of money, and it takes a lot of cardiology physician time to read all those ECGs, and that's where there's been hesitation in implementing that. In Italy, they do that.
In Houston, there's a study as well that they took all the high school students. They were looking for coronary artery anomalies, not so much Wolff Parkinson White and other SVT. They seem to have found some money to do that. Is this something that you're going to be elected to Congress to do, or what are your thoughts are?
It's a very difficult thought process because one of the downsides of doing an ECG on an otherwise normal child, and you look at a normal ECG and you tell the parent that, hey, we did an ECG on your child and it's normal, there's a false sense of assurance that goes with that. Because what if they do have a coronary anomaly and then a sudden death event happens? And so that's why the debate continues. Having said that, we participate in screening studies. So as part of our PEDS cardiology group, there are organizations that provide that for free for parents and for kids. When they want to come in, they'll do a screening event, and actually the participation in those, to me, seems relatively low. I think not as many parents take advantage of that to do that. But should it be universal? I think more people are starting to agree that, yeah, we probably should do it. I think we should follow the Italian example, just keeping in mind that we don't want to give false sense of assurance in those patients that are, quote, normal.
Well, I think we've reached 8 o'clock, and thank you very much, Dr. Trivedi, for a wonderful review. And this session is over.
Thanks. Thanks all.